Welcome to the deep dive. We take stacks of information, unpack them, and pull out the most vital knowledge and surprising insights just for you. Our mission today, to really get you up to speed, like an elite professional on a fascinating and complex subject.
Absolutely. We're going deep today into an area of infectious diseases that, honestly, is often overlooked but is so important for understanding how pathogens interact with us, with our bodies, and our environments. We're really aiming beyond just the surface today, mastering the intricacies of Bartonella infections.
Right. Today we're zeroing in on sources mainly centered around Chapter 172 from a comprehensive medical text. We want to explore everything from the microscopic details, the bacteria themselves, right through to the clinical picture, diagnosis, treatment, the cutting edge. This isn't just reciting facts, it's about building that foundational understanding so you can connect the dots, ask those critical questions, and really grasp the implications for public health and, well, for individual patients.
Exactly. Get ready to gain the kind of insight that, frankly, sets professionals apart. We want you to achieve a level of mastery, to see that bigger picture and understand the really nuanced challenges these pathogens present.
Okay, let's unpack this. We're starting with the genus Bartonella itself.
Mhm.
What exactly are we dealing with here, and why are these bacteria so, well, noteworthy?
Well, Bartonella species are truly remarkable microorganisms, almost like master survivalists in the bacterial world. They're described by a few key characteristics that make them particularly challenging. Challenging to study, to diagnose, and definitely challenging to treat. Let's break those down. First off, they are fastidious.
Fastidious.
Yeah, it basically means they have incredibly complex nutritional requirements. Think of like the pickiest eater you know, but make it a bacterium.
Okay.
They won't just grow anywhere. This pickiness makes them notoriously difficult to culture in a standard lab setting. You can't just use a regular agar plate.
Right, they need special treatment.
Exactly. Specialized nutrients, specific conditions, and this directly impacts diagnosis time using traditional methods and complicates research too. Next, they are facultative intracellular. This is a really crucial survival strategy.
Facultative intracellular, meaning?
Right. It means they have the option, the faculty, to live both inside and outside of our host cells, like having multiple hideouts.
Ah, clever. A bit of stealth mode.
Precisely. This adaptability gives them a huge advantage in evading the host's immune system. Once they slip inside a cell, they're often shielded from our defenses. It also lets them survive in different environments within the body, making them incredibly persistent. Third, they are slow-growing. This might sound minor, but the implications are actually major.
How so?
Well, when bacteria grow slowly in lab culture, it means diagnosis can be significantly delayed. Cultures might need incubation for weeks, not days.
Weeks. Wow, so you're waiting a long time for confirmation.
Exactly, which pushes back definitive identification and complicates treatment decisions. Clinicians might have to make empirical choices based on symptoms alone for quite a while. And finally, they are gram-negative bacteria. This is a basic classification based on their cell wall structure and how they stain. But importantly, their outer membrane acts as an extra protective barrier. This impacts which antibiotics work, as some drugs just can't get through that layer effectively. Knowing this helps guide treatment choices.
Okay, so fastidious, facultative, intracellular, slow-growing, gram-negative. That combination sounds like a recipe for a challenging pathogen.
It really is. And beyond these core traits, there's sheer diversity and adaptability within the genus Bartonella. We're talking over 40 distinct species or subspecies identified, over 40, and out of those, at least 16 are recognized as confirmed or potential human pathogens. So it's not just one bug, it's a whole family, each with its own quirks. The ones we most commonly see causing human disease are Bartonella bacilliformis, Bartonella quintana, and Bartonella henselae. These are kind of the big three we'll focus on.
Right. And you mentioned their survival strategies are pretty clever.
Oh, absolutely. Let's talk about their reservoirs and immune evasion. Most Bartonella species have adapted to survive long-term in specific mammals, domestic or wild. These animals act as persistent, often asymptomatic reservoirs. The key to this is prolonged intraerythrocytic infection.
Intra.
Uh-huh.
Inside the red blood cells.
Exactly. They can live inside red blood cells. Imagine being a tiny bacterium tucked away inside a host cell, floating around in the bloodstream, essentially invisible to the immune system.
That sounds like the perfect hiding spot.
It provides incredible protection. It shields them from both the innate immune system, the body's first responders, and the adaptive immunity, more specific antibodies and T cells. This hidden passenger strategy is why the infected animal can remain a persistent source, shedding bacteria without being sick itself.
And how do they pull off this immune evasion?
It's quite sophisticated. They characteristically evade the host immune system by modifying their own virulence factors.
They're weapons, basically.
Sort of, yeah. Components that help them cause disease, things like lipopolysaccharides on their outer membrane or their flagella, the little tails for movement. By altering these, they become less recognizable, less of a target. They also actively work to sort of dampen down or attenuate the host's immune response itself, preventing the body from mounting a really effective defense. It's a masterclass in adaptation.
So most come from animals, but not all.
Right, there are key exceptions. B. bacilliformis and B. quintana are different. They are not zoonotic. For these two, humans are the primary, often the only, reservoir.
Meaning the infection cycle is primarily human to human.
Correct, often with an arthropod vector, like an insect, acting as the go-between. And that brings us to the role of arthropod vectors. They're critical for many Bartonella species. We're talking fleas, lice, sandflies. Their involvement highlights the complex ecological cycles these infections are part of. It's often an ecological challenge as much as a medical one.
Okay, so putting it all together, this unique biology makes diagnosis and treatment a real headache.
Absolutely. All these characteristics, fastidious, slow-growing, intracellular, immune-evasive, contribute to the diagnostic challenges and therapeutic nuances. Isolation and characterization are tough, needing special lab techniques, long incubation times. Clinically, the presentation varies hugely depending on the Bartonella species, and critically, the host's immune status. An immunocompetent person might have a mild case, but someone immunocompromised could face severe systemic disease.
And treatment isn't straightforward either, you mentioned.
That's a crucial insight, especially digging into Chapter 172. While Bartonella species might look susceptible to many antibiotics in vitro in the test tube clinical responses, and animal studies show a poor correlation between these lab results, the MICs, and how well the drugs actually work in vivo inside a living body.
So what works in the lab doesn't always work in the patient. Why is that?
It's a great question. It likely relates to their intracellular niche, maybe the slow growth, or other evasion tactics that let them escape the full antibiotic effect within the body. This poor correlation means we can't just pick any drug that looks good on paper. We need specific, proven regimens, often for extended periods, to really succeed.
That makes perfect sense. So the core challenge is their biology makes them hard to find, hard to grow, and hard to kill effectively in the body. How do these foundational aspects play out in the specific diseases we see? Can you give some examples of the species-host-vector relationships?
Precisely. Understanding this foundation is the map for our journey into specific diseases. Let's look at some key examples from Table 172 to 1 in the source material. Take Bartonella henselae. It's the main cause of cat scratch disease, but it's also linked to more serious things like Bacillary Angiomatosis, Pileosis, bacteremia, endocarditis, its reservoir. Domestic cats, other felines, they often carry it without symptoms. And the vector between cats is often the cat flea.
Go cat fleas between cats. Got it.
Then there's Bartonella quintana, causes trench fever, but also chronic bacteremia, Bacillary Angiomatosis, endocarditis. Uniquely, humans are the only known reservoir here, and the vector is the human body louse.
Ah, the louse. So conditions of crowding, poor hygiene.
Exactly. That's where you tend to see it reemerge. And Bartonella bacilliformis, the cause of Carrion's disease. Again, humans are the only reservoir, but it's transmitted by specific sandflies, mainly in the Andes.
Very specific geography there.
Very specific. And the diversity goes further. Bartonella elizabethae, linked to endocarditis. Reservoirs, maybe rats, dogs. Subspecies of Bartonella vinsoni, linked to endocarditis, febrile illness, found in mice, dogs, coyotes, foxes, potential vector, ticks. Bartonella washoensis can cause endocarditis, myocarditis, meningitis, found in squirrels, possibly other rodents, vectors, fleas.
Ticks seem to pop up a few times there as potential vectors.
They do. And this is an important nuance, especially thinking critically about the source material. It mentions that some animal-associated Bartonella, including B. henselae, have been found in patients reporting tick bites and chronic symptoms like fatigue, muscle aches. Similarly, Bartonella DNA has been detected by PCR in blood from patients with lots of arthropod exposure and chronic neurological issues.
So ticks could be transmitting Bartonella to humans?
It's an association that's being investigated. But, and this is crucial, the definitive causal link between these specific Bartonella species, tick bites, and these chronic clinical syndromes isn't fully established yet. It encourages critical thinking. We see the association, but causation needs more robust evidence. It definitely opens doors for more research into ticks and Bartonella.
Fascinating complexity. Okay, from that broad overview, let's zoom in on Bartonella henselae and its most common phase. Cat scratch disease, CSD. We've all heard of it, but you're saying it's more than just a swollen lymph node.
Indeed. CSD is usually self-limited, yes, but its clinical forms are incredibly varied. It really can be a chameleon. We generally talk about two forms: typical CSD, that's the common one, characterized by subacute regional lymphadenopathy, swollen, often painful lymph nodes near the scratch or bite. Then there's atypical CSD. This is basically an umbrella term for numerous extranodal manifestations.
Extranodal meaning beyond the lymph nodes.
Exactly. The infection has spread, affecting various organs. It indicates a systemic reach. And while B. henselae is the main culprit, rare cases are linked to Aphiophilis or other Bartonella species. But mostly, it's henselae.
Okay. And where do we see CSD most often?
It occurs worldwide, but it likes warm, humid climates. In temperate zones, there's a peak in fall and winter, maybe related to cat activity or people getting new kittens around holidays. Adults get it almost as often as kids, despite the name. And critically for prevention, intrafamilial clustering is rare, and person-to-person spread does not happen.
Good to know. So it comes from...
Apparently, healthy bacteremic cats are the major reservoir. They carry B. henselae in their blood, often without symptoms. Cat fleas probably transmit it between cats, keeping the cycle going in felines, but fleas aren't usually the direct cause of human infection.
So how do humans get it then?
It usually follows contact with cats, especially kittens, which are more likely to be bacteremic and maybe scratch more. The thinking is the cat gets B. henselae-laden flea feces on its claws or in its mouth from grooming. Then a scratch or bite inoculates the bacteria, possibly mixed with saliva, into the human skin.
Ah, so it's contaminated claws or saliva, not the flea biting the human.
Generally, yes. Also, infection of mucous membranes, like the eye, can happen via droplets or licking. Once it's in an immunocompetent host, lymphatic drainage carries it to regional lymph nodes. This triggers a Th1 immune response, leading to that characteristic necrotizing granulomatous lymphadenitis.
Necrotizing granulomas. It sounds like inflammation and some tissue damage in the node.
Exactly. The body tries to wall off the infection, forming these granulomas, but there can be some central necrosis or tissue death. Dendritic cells and chemokines orchestrate this whole inflammatory process. In the U.S., the incidence is roughly 5 cases per 100,000 people, and about 5% need hospitalization, so it can be serious sometimes.
Okay, so what does this look like clinically? You mentioned typical and atypical forms.
Right. Typical CSD is the majority, 85–90% of cases. Often starts with a primary lesion at the inoculation site, a small, maybe 0.3 to 1 centimeter, usually painless red bump or pustule, appears within days to 2 weeks in maybe a third to two-thirds of patients, often missed.
Then the lymph nodes.
Yes, lymphadenopathy develops 1 to 3 weeks later, sometimes longer. Nodes are enlarged, usually painful. Skin over them might be red, about 10% sepiate-form pus.
Where are these nodes typically found?
Most commonly axillary or epitrochlear armpit and elbow area, then head neck, then inguinal femoral in the groin. About half of patients get systemic symptoms: fever, malaise, anorexia. A smaller group gets weight loss, night sweats, which can mimic lymphoma, making diagnosis tricky. Fever is usually low grade but can spike. Resolution is slow, weeks for symptoms, months for nodes to shrink fully.
And the atypical forms, that's where it gets really complex.
That's where the chameleon act really comes in. Atypical CSD happens in 10–15% of cases, with or without the lymphadenopathy. It represents systemic spread. We see ocular manifestations. Paranose oculoglandular syndrome, that's granulomatous conjunctivitis with swollen nodes in front of the ear on the same side. Also neuroretinitis, often causing unilateral vision loss and other eye issues.
Eyes, okay. What else?
Visceral involvement affecting internal organs, especially hepatosplenic disease, so liver and spleen lesions. Neurologic manifestations can be serious. Encephalitis, brain inflammation, seizures, myelitis, spinal cord, cerebellitis, cerebellum, facial or other nerve palsies.
Wow, that's a huge range.
It is. Also severe constitutional syndromes, fever of unknown origin, FUO, pneumonitis lungs, debilitating muscle pain, myalgia, arthritis or joint pain, arthralgia, especially in women over 20, osteomyelitis, bone infection, sometimes in multiple spots, tendinitis, various skin rashes. There's even a specific CSD-associated FUO syndrome that often mimics cancer, multi-organ involvement, abdominal chest nodes, eye disease, bone lesions. Fever can be continuous or relapsing.
And other things linked to it.
Yes. Pleural effusion, fluid around lungs, ITP, low platelets, Henoch-Schönlein purpura vasculitis, erythema multiforme, skin rash, glomerulonephritis, kidneys, myocarditis, heart muscle, and age matters. Elderly patients often lack the swollen nodes but are more likely to get cephalitis or FUO.
So despite all this, the prognosis is generally good.
In immunocompetent people, yes. Typical and atypical CSD usually resolve without treatment and without lasting problems, though rarely eye issues can cause significant vision loss. Lifelong immunity is generally the rule.
That's an incredibly wide range of symptoms
Yep.
from just a cat scratch. So given all these possibilities, how do clinicians actually nail down the diagnosis? It sounds like it could mimic almost anything.
It's a real diagnostic maze, absolutely. Routine lab tests, usually normal or nonspecific, not much help initially. Histopathology, looking at tissue samples, can show characteristic changes lymphoid hyperplasia early, then those stellate granulomas with necrosis, microabscesses, not specific only to CSD, but helpful to narrow things down.
What about blood tests for antibodies?
Serologic testing is the most common approach, using IF or EIA to detect antibodies. But sensitivity and specificity vary. Often, diagnosis relies on IgG alone, which can persist long after infection, making interpretation tricky. Plus, seroconversion developing detectable antibodies takes a few weeks, so an early test might be falsely negative.
Are other tests useful? Culture? Staining?
Generally less so for routine diagnosis. Culture has low sensitivity, needs special conditions. Special silver staining also has low sensitivity. Cytology, histopathology alone lacks specificity. PCR and immunohistochemistry are good, highly specific, but often not readily available everywhere.
So what's the best bet for a definitive diagnosis, the gold standard?
PCR of pus aspirated from a lymph node or the primary lesion that's highly sensitive and specific, really useful for rapid diagnosis, especially if serology is negative early on. PCR on a lymph node biopsy specimen is also very important.
Okay, so PCR on fluid or tissue is key. How does clinical suspicion fit in?
It's paramount. History of cat contact, a primary lesion, regional nodes, especially axillary epitrochlear, that's highly suggestive. Confirmation comes from the clinical picture plus corroborative lab tests. But ruling out malignancy is crucial, especially if antibody tests are negative, happens in 10–20% of cases, if nodes don't shrink, or if systemic symptoms persist. The differential diagnosis is broad bacterial infections, mycobacteria, toxoplasmosis, fungal infections. Lots to consider.
So what's the typical diagnostic path?
If CSD is strongly suspected clinically in someone who's seronegative, fine needle aspiration with PCR might be enough. If the picture is less clear, a lymph node biopsy is often preferred for more definitive info. Early biopsy is important for seronegative patients with severe complications like encephalitis or neuroretinitis, where a quick, accurate diagnosis is vital.
Makes sense. And what about treatment? You said it often resolves on its own, but what if it doesn't or if it's severe?
Right. Treatment regimens are based on minimal data, honestly, because many cases resolve spontaneously. If nodes separate, form pus, they need drainage. But it's key to use large-bore needle aspiration, not incision and drainage, to avoid chronic draining tracts. Systemic antibiotics are generally recommended for immunocompromised patients as their disease can be more severe.
And for typical CSD in healthy people?
Not routinely indicated. If lymphadenopathy is expensive or really bothersome, maybe consider azithromycin for a short course.
What about the atypical, more serious forms like neuroretinitis?
The value of antibiotics there is debated, especially if vision isn't badly affected. For more severe cases, though, a combination like doxycycline plus rifampin for 4–6 weeks is often given. Sometimes systemic steroids are added.
And other atypical forms like encephalitis or liver spleen involvement?
Similar approach, often doxycycline plus rifampin, but the duration is individualized. Data on efficacy for these are lacking, but that combo is considered reasonable.
And finally, prevention.
Pretty straightforward. Avoiding cats, especially kittens, instituting good flea control. This is particularly important for immunocompromised individuals or those with heart valve disease who are at higher risk for severe outcomes.
Got it. So CSD, definitely more complex than the name suggests. Now let's shift gears from the familiar cat connection to a disease with a really striking history that's making a comeback. Trench fever.
Yes, trench fever is a fascinating example of a disease tied to specific conditions. Also known as 5-day fever or Quintan fever, caused by Bartonella quintana. First described during the massive epidemics in the World War I, trenches. Horrific conditions, close quarters, body lice, perfect storm.
But it's actually much older than WWI.
It seems so. Paleomicrobiological studies suggest B. cantana has been infecting humans for maybe 4,000 years, an ancient pathogen. After decades of being almost forgotten, it has reemerged, often presenting as chronic bacteremia, particularly in homeless populations, sometimes called urban or contemporary trench fever.
A reemergence tied to specific populations.
Exactly. Beyond the World War epidemics, sporadic outbreaks occurred globally. The vector is the human body louse, Pediculus humanus corporis, and humans are the only known reservoir. These recent reemergent clusters, mainly reported from the US and France, are often in HIV-uninfected homeless individuals. Alcoholism and louse infestation are consistently identified as major risk factors. It really highlights the link between social determinants and infectious diseases.
And clinically, what does trench fever look like? What's the 5-day fever part?
The incubation period is usually 15-25 days, but variable. The classical description from 1919 ranged from mild fever to a debilitating recurrent illness. The characteristic feature is the periodic fever. Lasts 4 to 5 days, then an interval of about 5 days, range 3 to 8 days, before the next episode, hence 5-day or quinton fever.
What other symptoms go along with the fever?
Headache, often severe, back and limb pain, profuse sweating, shivering, muscle aches, myalgia, joint pain, arthralgia, enlarged spleen, splenomegaly, occasionally a maculopapular rash. Some cases had neck stiffness. Untreated, it usually lasts 4 to 6 weeks. Death is rare, fortunately. Today, in homeless populations, the spectrum of B. cantana bacteremia goes from asymptomatic infection to a febrile illness with severe headache, muscle, and joint pain, sometimes joint disease, arthropathy.
A disease from a century ago reappearing. Really striking. How do we spot it today, particularly in these at-risk groups where symptoms might be overlooked?
Diagnosis is definitely key. Definitive diagnosis requires isolating B. cantana from blood culture. Some patients can have positive cultures for weeks, indicating persistent bacteremia. Serology can help. Acute trench fever patients usually develop antibodies. But here's a major pitfall. Those with chronic B. cantana bacteremia might be seronegative. Their antibody tests could be negative despite active infection.
So serology isn't always reliable in chronic cases.
Exactly. You can't rely on it alone there. Also, if someone does have high IgG antibody titers, they absolutely need evaluation for endocarditis, that serious heart complication. And in epidemic settings, you have to differentiate it from other louse-borne diseases like typhus or relapsing fever, which share features and occur in similar conditions.
And treatment. How do we manage it now?
Recommendations come partly from a small randomized trial in homeless people with B. cantana bacteremia. It showed therapy is important, even if symptoms are mild, primarily to prevent endocarditis. Optimal therapy if bacteremia isn't documented is less certain. For documented B. cantana bacteremia, the recommended regimen is typically combination therapy. Gentamicin intravenously for about 14 days, plus doxycycline orally for about 6 weeks. This aims to clear the infection and prevent complications.
Okay, from trench fever, let's move to another serious complication. Bartonella endocarditis. You mentioned it's often culture negative. That sounds like a recipe for a hidden threat to the heart.
It absolutely is a very serious manifestation, and diagnosis can be incredibly elusive. Bartonella species, along with Coxiella burnetii, Q fever, are the most common culprits found in culture-negative endocarditis, meaning standard blood cultures are negative, which immediately makes diagnosis harder.
How common is Bartonella in these cases?
It varies geographically. In France, for example, Bartonella was identified in about 28% of a large group of culture-negative endocarditis cases. That's significant. The most common species involved are B. cantana and B. henselae, with cantana reported more often than henselae. Other Bartonella species cause rare cases, too.
And who is most at risk?
It's reported worldwide, mostly affects adults, with more men than women. For B. cantana endocarditis, risk factors include homelessness, alcoholism, louse infestation linking back to trench fever. But importantly, it can also hit people with no obvious risk factors. For B. henselae endocarditis, the link is exposure to cats. It usually affects native heart valves more than prosthetic ones, and the aortic valve is involved in about 60% of cases.
Is there a difference in who gets which type?
Interestingly, yes. Patients with B. henselae endocarditis usually have pre-existing valve problems, but B. cantana often infects previously normal valves,
making B. cantana potentially even more insidious.
Exactly. Clinically, it usually presents as subacute endocarditis developed slowly, but many patients have a prolonged, minimally febrile or even a febrile indolent illness, mild, nonspecific symptoms lasting weeks or months before diagnosis. This makes it incredibly tricky to catch early. Initial echocardiograms might not even show vegetations, a acute aggressive disease is rare. It's usually this slow, smoldering infection.
So it's often hidden, making early detection incredibly hard. How on earth do clinicians find this elusive pathogen then? What's the strategy when standard blood cultures fail?
That's the million-dollar question. How do you diagnose something that hides so well, especially with the heart involved? It's a multi-pronged quest. First, blood cultures. Even using special techniques, they're positive only about 25% of the time, mostly for B. cantana, rarely for B. henselae, and they need prolonged incubation, up to 6 weeks. Too slow for urgent decisions.
So cultures aren't very reliable. What about antibodies?
Serologic tests, IF or EIA, are very important. They usually show high levels, titers 1.800 of Ig antibodies to Bartonella. That's a strong clue. But there's a challenge: cross-antigenicity. Routine serology doesn't reliably distinguish between B. cantana and B. henselae, and it might show low-level cross-reactions with Coxiella or chlamydia.
So a positive antibody test points towards Bartonella, but maybe not the exact species,
Yeah.
and you have to consider cross-reactions.
Precisely. For definitive species identification, you typically need PCR and DNA sequencing directly on valve tissue. This highlights how crucial tissue biopsy, often from heart surgery, can be for a precise diagnosis when other methods fall short.
And treatment, especially if it's suspected but not confirmed.
For suspected culture-negative endocarditis, where Bartonella is on the list, empirical treatment starts broad, usually a combo like gentamicin, doxycycline, and ceftriaxone. The ceftriaxone is mainly there to cover other potential causes of culture-negative endocarditis. Once Bartonella is confirmed, usually by valve PCR, the ceftriaxone is stopped.
And for confirmed Bartonella endocarditis.
The critical component is an aminoglycoside, like gentamicin. These are the only antibiotics known to be bactericidal, actively killing Bartonella. They must be included for at least 2 weeks. Some experts recommend a specific gentamicin dose. If gentamicin can't be used, maybe add rifampin to doxycycline. Doxycycline is given for a long time, typically 6 weeks, usually orally or IV twice daily. Some experts recommend extending oral doxycycline for 3 to 6 months to prevent relapse.
And surgery.
Valvular surgery indications are the same as for other types of subacute endocarditis, but the proportion needing surgery is high, around 60%, likely because diagnosis is often delayed, leading to significant valve damage.
Delayed diagnosis leading to more surgery. That really underscores the challenge.
Yeah.
Okay, let's switch focus now to conditions hitting immunocompromised individuals at Bacillary Angiomatosis and Peliosis. How does Bartonella cause these unusual growths?
It's fascinating how Bartonella triggers these distinct angioproliferative lesions, abnormal blood vessel growth, especially when the immune system is weak. Bacillary Angiomatosis, BA, sometimes called bacillary epithelioid angiomatosis, primarily affects severely immunocompromised patients, classically those with advanced HIV/AIDS. It's caused by either B. henselae or B. cantana, characterized by these new vascular growths in various organs.
Do both species cause the same lesions?
Both cause skin lesions, but lesions in the liver and spleen, hepatosplenic, seem to be caused only by B. henselae. Subcutaneous nodules and lytic of bone lesions are more often linked to B. cantana. Then there's bacillary peliosis, BP, also caused by B. henselae. It mainly involves the liver, Peliosis hepatas, but also spleen and lymph nodes. BP is characterized by blood-filled cystic structures, like tiny blood blisters inside the organs, different from the solid growths of BA.
And who gets these conditions?
Primarily HIV-infected individuals with very low CD4 counts, usually below 100, but also other immunosuppressed patients, like transplant recipients, rarely even immunocompetent people. A key point is that the incidence of BA and BP drops significantly with effective antiretroviral therapy, ART, for HIV. Also, preventive antibiotics used for other infections and AIDS likely helped. It shows the impact of managing the underlying immunodeficiency.
What are the risk factors for getting the Bartonella in the first place?
For B. henselae infection leading to BADP, it's contact with cats or cat fleas, similar to CSD. For B. cantana infection, it's low income, homelessness, body louse infestation, echoing trench fever epidemiology.
So these are opportunistic infections manifesting as unusual growths. What do they actually look like, particularly the skin lesions, and how are they diagnosed?
The clinical presentation can be quite distinct, especially on the skin. In bacillary angiomatosis, the most common sign is one or more skin lesions, typically painless, tan, red, or purple. Can also be subcutaneous nodules, often tender, superficial ulcerated plaques, or even wart-like verrucous growths. The nodular forms can mimic fungal or mycobacterial infections.
What about other sites? Bones?
Yes, osseous lesions can occur, painful bone lesions, often in long bones, maybe underskin lesions or develop separately. X-rays show autolytic areas, bone destruction. Bone scans show increased uptake. Patients usually have constitutional symptoms too: fever, chills, malaise, headache, anorexia, weight loss, night sweats. Both B. henselae and B. cutana are important causes of FUO in advanced immunodeficiency. When diagnosing cutaneous BA, you need to differentiate it from things like Kaposi sarcoma or pyogenic granuloma. For bacillary ileosis, imaging usually shows hypodense areas in the liver, indicating the blood-filled cysts.
And under the microscope, what are the pathological clues?
For BA, histology shows lobular proliferations of small blood vessels lined by enlarged endothelial cells with inflammatory infiltrates, mostly neutrophils. For BP, you see these small blood-filled cystic spaces, partially lined by endothelial cells, maybe several millimeters across, surrounded by fibromyxoid stroma with inflammatory cells and clumps of granular material. The key diagnostic stain is the Warkin starry silver stain. It reveals characteristic clusters of bacilli, the Bartonella bacteria, in both BA and ileosis lesions. Cultures are usually negative, though.
So diagnosis relies heavily on biopsy and that special stain.
Primarily, yes. Histologic examination is key. Blood cultures might occasionally be positive, but it's challenging.
And treatment. Given the weakened immune system, I assume it needs to be thorough.
Absolutely. Prolonged therapy with a macrolide or doxycycline is recommended for both BA and BP. Typical regimens involve erythromycin or doxycycline for several months, maybe 3 months for BA, 4 months for ileosis. Other macrolides are probably also effective. The long duration is crucial to clear the infection and prevent relapse in these patients.
What about prevention, especially for HIV patients?
Reasonable strategies include controlling cat flea infestations and avoiding cat scratches for B. henselae, and avoiding treating body louse infestation for B. cutana. Importantly, primary prophylaxis, giving antibiotics routinely to all HIV patients to prevent BABP, is not recommended. However, suppressive therapy with a macrolide or doxycycline is indicated for patients who've already had BA or BP. This continues until their CD4 counts recover, for example, 200, or possibly lifelong if relapses occur.
A targeted approach based on history and immune status. Okay, shifting geographically now, let's tackle Carrion's disease. You mentioned it's biphasic and restricted to the Andes. What's the story here?
Carrion's disease is fascinating, really illustrating how geography and vectors shape disease. It's a biphasic illness caused by Bartonella bacilliformis. Phase 1 is Arroyo fever, the initial acute bacteremic systemic form, often severe. Phase 2 is Verruga peruana, the late-onset eruptive skin manifestation, 2 distinct phases of one infection.
And why only in the Andes?
It's endemic only in specific Andes valleys in Peru, Ecuador, Colombia, usually at elevations between 500 and 3,200 meters. Sporadic epidemics can occur. This restriction is due to its vector, the phlebotomine sandfly, specifically Loopsomia vericarum. Its habitat dictates the disease's range.
So transmission is primarily through this sandfly?
Primarily, yes. Though rare maternal-fetal transmission and transmission via blood transfusion have been reported. And uniquely, humans are the only known reservoir for B. bacilliformis, no animal reservoir. Prevention focuses on sandfly control, insecticides, and personal protection, repellents, screens, bed nets.
How does the infection progress? What's the pathogenesis?
After the sandfly bite, bacteria invade the blood vessel endothelium and proliferate there. The reticuloendothelial system and other organs can get involved. The key step for Arroyo fever is when B. bacilliformis re-enters the bloodstream, invades red blood cells, replicates inside them, and ultimately destroys them. This causes massive hemolysis,
Leading to severe anemia.
Exactly. Sudden, severe anemia. Microvascular thrombosis, small clots, can cause organ damage due to lack of blood flow, ischemia. Survivors sometimes later develop the Verruga peruana lesions, these cutaneous hemangioma-like growths containing endothelial proliferation, inflammatory cells, and the Bartonella bacteria themselves.
A disease with 2 starkly different phases. How does this look clinically? And how do you diagnose it when it could be either the acute fever or the later skin lesions?
It presents unique diagnostic challenges. Incubation is typically 3 weeks, range to 14 weeks. Arroyo fever, acute phase, can range from a nonspecific febrile illness without much anemia to that acute, severe hemolytic anemia with enlarged liver, jaundice, potentially vascular collapse, confusion. Other symptoms: muscle joint pain, swollen nodes, abdominal pain. Fever is usually elevated but not extremely high. Very high fever might suggest a co-infection like salmonella. Subclinical infection also occurs. And the second phase, the skin lesions. Verruga peruana, eruptive phase. Red, hemangioma-like skin lesions of various sizes. Appear weeks to months after Arroyo fever, or sometimes with no prior history of acute illness. Lesions can persist for months, up to a year. Can also occur on mucous membranes or internally.
Diagnosis sounds tricky then, depending on the phase.
It is. Clinical suspicion is key. Systemic illness with or without anemia, or the characteristic skin lesions in someone who's been to an endemic area. Lab findings in Oroya fever can include severe anemia with high reticulocytes, sometimes low platelets. A crucial diagnostic clue in the acute phase is seeing the intraerythrocytic bacilli on gene-sustained blood films. Direct visualization.
You culture it.
Blood and bone marrow cultures may be positive, but growth is slow, 1 to 6 weeks, and needs lower temperatures. Serology can also be helpful. Verruga peruana diagnosis is often clinical, based on the lesion's appearance, though biopsy might be needed. PCR assays exist, but aren't standard routine tools yet. Differential diagnosis includes other fevers common in the region, typhoid, malaria, brucellosis, or other causes of vascular skin lesions, hemangiomas, BA, Kaposi sarcoma.
And treatment. How do you target these different phases?
For systemic B bacilliformis infection, Oroya fever, antibiotic therapy usually brings the fever down quickly. Often need to treat co-infections too, especially salmonella. Blood transfusions may be vital due to severe anemia. Recommended regimens include chloramphenicol, often with another antibiotic, or ciprofloxacin, plus ceftriaxone.
What about the verruga peruana skin lesions?
Treatment isn't always required. They can resolve spontaneously. But patients with many lesions, especially recent ones, may respond well to antibiotics. Options include azithromycin, ciprofloxacin, rifampin, or streptomycin.
What's the prognosis? Oroya fever sounds very dangerous.
It is. Mortality rates without treatment have been reported as high as 40%. With treatment, it's much lower, around 10%. Timely intervention is critical. Complications are common. Bacterial superinfections, neurologic issues, cardiac problems. Certain signs like massive edema, anasarca, or petechio suggest a poor outcome. Good news is survivors usually develop permanent immunity.
We've covered a lot of ground really digging into the details of these distinct Bartonella infections from Chapter 172. So pulling it all together, what are the big picture takeaways for treatment and prevention across the board?
Yeah, stepping back, if we connect all these dots, you see that despite the diversity, there are overarching principles, especially around therapy and avoiding infection. Let's revisit treatment nuances. We stressed early on that in vitro susceptibility doesn't always predict in vivo efficacy. That's a core challenge from the chapter. We need evidence-based regimens, not just lab results. A common thread is the use of macrolides and doxycycline. We saw azithromycin for CSD, erythromycin doxycycline for BABP, options for verruga peruana. They're versatile against Bartonella
And the aminoglycosides.
crucial. Their unique bactericidal activity is vital, especially for severe infections like endocarditis, often a required part of the initial aggressive treatment. We also saw the need for prolonged therapy weeks to months for serious infections. That's characteristic, needed to eradicate these persistent bugs. The strategy of empirical versus confirmed treatment also emerged, starting broad for suspected severe cases like culture-negative endocarditis, then narrowing therapy once Bartonella is confirmed. We noted the high rate of surgery in Bartonella endocarditis, often due to delayed diagnosis, and the need to manage complications alongside antibiotics transfusions for anemia in Oroya fever, aspiration for CSD nodes.
Okay, treatment requires specific drugs, often long durations, and managing complications. What about prevention? Any common themes there?
Definitely. Arthropod control is huge. Fleas, lice, sandflies, controlling these vectors is key for many Bartonella diseases. Examples: flea control for cats, CSD BABP, louse eradication, trench fever BABP, sandfly control, Carrion's disease. Animal contact management is another. Avoiding specific reservoirs, especially for the immunocompromised. For example, cats, kittens for CSD B. Hensley, BABP. For diseases where humans are the reservoir, trench fever, Carrion's disease. Public health measures targeting human infection and transmission are vital. We should also briefly mention blood safety. The rare but real risk of transfusion transmission needs ongoing vigilance, though things like leukodepletion help reduce it. And focusing on immunocompromised patients, specific prevention like suppressive therapy after BABP until immune recovery, even if primary prophylaxis isn't retained.
So vector control, animal contact management, public health for human reservoirs, and special attention for vulnerable patients.
Exactly. And underpinning all of this is the power of timely diagnosis. We saw repeatedly how delays lead to worse outcomes. That detailed knowledge from sources like Chapter 172 is crucial for clinicians to recognize these varied presentations early.
Before we wrap up, our source material did briefly touch on a couple of other related infectious disease topics. Let's just quickly acknowledge those for a complete picture without losing our Bartonella focus.
Right. These brief mentions just highlight the broader context. There was a bit on Yersinia, another bacterial challenge. Prevention is similar to other enteric bugs like Salmonella safe food handling, especially pork. No effective animal vaccine exists. Discouraging raw pork consumption, care with things like chitterlings. Abattoir techniques have improved but not eliminated carcass contamination. Vigilance is needed in the food industry. Blood transfusion contamination with Yersinia is rare but hard to eradicate completely. Leukodepletion helps but doesn't eliminate risk. And a brief note on reactive arthritis treatment after Yersinia infection. Some trials showed mixed results for antibiotics affecting long-term outcome, though maybe faster initial relief in some cases. Yersiniosis is notifiable in some places.
Okay, and the other quick mention.
Donovanosis, or granuloma inguinale, from Chapter 173. A chronic bacterial STI, mainly genital, caused by Klebsiella granulomatis. Low infectivity associated with poor hygiene, seen in specific geographic areas like Papua New Guinea, parts of Africa, India, Australia. Incidence has decreased significantly, possibly due to better management of genital ulcers generally, given their link to HIV transmission. It's a risk factor for HIV itself. Diagnosis involves finding characteristic Donovan bodies.
Right, important context, but distinct from our main focus today.
Exactly. We've truly gone granular on Bartonella today, exploring everything from their survival tricks to their diverse clinical impacts and the specific strategies needed to tackle them. This deep dive into Chapter 172 should really provide a robust framework for understanding these pathogens like never before.
What an incredible journey. Through such a complex, often really insidious group of diseases, we've peeled back the layers, revealing not just the what, but the why and how. Our hope is that you, our listeners, now feel truly well-informed, armed with that nuanced understanding that only really digging deep can provide.
And this really raises an important question for you, the listener. How might understanding this interplay between pathogen, host immunity, environment, and Bartonella infections shape your perspective on other emerging or re-emerging infectious disease challenges in our very interconnected world?
Exactly. Think about how that knowledge applies elsewhere. Thank you for joining us on this deep dive. Until next time, keep that curiosity alive.